Hello, everyone, and welcome to the second webinar in our series from AHA's Better Health for Mothers and Babies initiative. I am Julia Resnick. I'm Senior Director in the Division of Health Outcomes and Care Transformation here at the AHA, and I will be your moderator for today's webinar. I will jump right in and just take a few seconds to level set about why we're all here. In short, maternal morbidity and mortality rates in our country are just too high. And we know that some communities have higher rates of harm than others. We also know that our healthcare system can and must do better for our families because losing one life is too many. The good news here is that 80% of pregnancy-related deaths are preventable. And through AHA's Better Health for Mothers and Babies initiative, we are working alongside hospitals and health systems to help mothers and their babies thrive. Our shared goal is to eliminate preventable maternal mortality and reduce morbidity related to pregnancy and childbirth. The Better Health for Mothers and Babies initiative is guided by 4 core principles that you can see here. Our first session in the webinar series touched on the first core principle around data. If you haven't seen that yet, it was a really great presentation, and I would encourage you to visit our website and watch the YouTube archive. But today we're zooming in on core principle number 2, considering the causes of disparities in health outcomes and designing care accordingly. After today's webinar, you'll be able to explore our discussion guide and action plans that will help foster conversations with your team and with your community on how you can reduce disparities in maternal outcomes. So today we're lucky to be joined by 4 maternal health experts from across the country who will share how their healthcare organizations are making birth safer for moms and their babies. First, you'll hear from Tamika Augusti and Laurel Patchen from MedStar Washington Hospital Center. That will be followed by Kristen Farney and Ashley Polnitz of Carle Health, who will share their work in Illinois. So I'll be turning it over to you, Drs. Augusti and Patchen.
Thank you so much, and thank you for having us. We're very excited to speak about our wonderful program, Safe Babies, Safe Moms, which just to level set, it's a community-based initiative or program to improve maternal health. So a little bit more about Safe Babies, Safe Moms. It is a very comprehensive program to improve maternal and infant health outcomes by addressing not just the medicine, but also the health disparities, particularly for Black birthing individuals and their families in Washington, D.C. I'd be remiss if I didn't say that this amazing program was made possible by a very generous grant from the A. James and Alice B. Clark Foundation. And this program really does do comprehensive family-centered care from pre-pregnancy, well woman, all the way through childhood. And I'll show a little slide on that a little bit later. One of the other things that I want everyone to take home is that this program could not have been done in isolation. We had to do this with our community partners. So some of them are listed there. One of the FQHCs in the District of Columbia, Community of Hope, Georgetown University McCourt School of Policy, Georgetown's Health Justice Alliance, and of course, the Clark Foundation. And so our program was really a true care continuum. We started with pre-pregnancy around wellness, through pregnancy, delivery, postpartum, and then taking care of the whole family unit, including the infant up to age 3. We've had lots of care coordination. We brought in not just OBGYN, but community pediatrics, family medicine, child, adolescent, and adult psychiatry, and all of our community partners. The one other thing that I wanted you to take away from this is the research that we did around outcomes, findings. We really started weaving that in through all of the care and working very, very hard to disseminate some of those findings. So we're pretty proud of that. The services, like I mentioned really quick, complete prenatal, antenatal, postpartum care and education, mental health services for both the birthing individual and the family, breastfeeding support, normal routine health screenings, well child, well woman visits, nutritional information, legal services, some support services around access to food, diapers, childcare essentials, transportation, etc. Those are the locations in the District of Columbia that we had a site at. You can see it varies from academic centers, tertiary care centers, community health centers, and everything in between. So we are very, very proud of that. I'd like to highlight some of the milestones just because we're so proud of the work that we did. So very, very briefly, we started services in this program November of 2020. We launched that. And then we're rolling, we're going, and about a little over 2 years later, our Community of Hope Community Health Center was able to get a high-risk obstetrical specialist or maternal fetal medicine to have a practice within the community health center. That practice is still going on. That practice is expanding, more time there, so that is really wonderful. And then as we move on to March of 2022, we realized that we really wanted to have one space that was beautiful and what our patients deserved, but also a space that integrated all the services, not just the OBGYN care, the high risk care, social services, behavioral health. So we brought that all together and opened a beautiful site for our patients in Safe Babies, Safe Moms in March of 2022. Then about a year later in January of 2023, this was truly the first national publication that highlighted the work that we're doing. It was highlighted in the Joint Commission Sentinel Event Alert on National Maternal Health, Health Equity, and Mental Health. Then later in 2023, we were selected as a 2023 Commitment to Action project by the Clinton Global Initiative. And we are very proud of that. We've done a lot of good work and we're continuing to do good work. And hopefully you'll hear a little bit more about MedStar Health and the Clinton Global Initiative the next couple of months. And then our icing on top, or the cherry on top, that we were so proud of is in January 2025, we were able to publish a study in New England Journal of Medicine Catalyst that found that Safe Baby, Safe Mom patients did have better pregnancy outcomes, delivery, and postpartum outcomes. So truly, truly very, very proud of the work that we've done. So I'm going to get right to it. We're going to talk about the wonderful outcomes that we had. There's a lot on this slide. I'm not going to read all of it, but you can see how many patients we served, how many babies have been born, and look at the amazing outcomes that we've had for patients who did receive prenatal care through the program. We're seeing fewer cases of severe maternal morbidity and mortality among preeclampsia cases, among very low birth weight babies, low birth weight babies, and babies born preterm. That's pretty amazing. That is wonderful. We saw similar decreases in patients who just have Medicaid insurance when compared to those that have commercial insurance. And continuing to do a great job with closing the disparity gap. So we can see that our Black patients receiving prenatal care under the program, they too had less and fewer very, very low birth weight babies, cases of severe maternal morbidity overall, and et cetera. So I hopefully you'll be able to see the slides. We want to leave this up. We are so proud of the work that we've done and what we've been able to accomplish in the District of Columbia. When we look back on the program, we did a lot of discussion about what were the high impact services on the maternal health. What do we think really made the difference? And they were the top four. The social drivers of health, the maternal mental health services, the services around hypertensive disorders or pregnancies, and perinatal diabetic education and management. Without a doubt, those were the four that made the biggest difference in our patients. So I'm going to have my partner in this, Laurel, talk about what some of those key lessons were. So I'm going to turn it over to you, Laurel, and just let me know when you want to advance the slides.
Perfect. Thanks so much, Dr. Auguste. Good morning or good afternoon, everyone. Excited to be here and just want to talk a little bit about some of the key lessons that we acquired over the first 5 years of implementing this program around those areas that Dr. Auguste just mentioned, which we think were really the high impact areas of work. So as I'm sure you all are aware, social drivers of health account for a large proportion of outcomes clinically. And so one of the first things that we did was implement a comprehensive assessment around social drivers of health. Key lessons here were to make sure that we used and adopted a trauma-informed approach in terms of asking questions where we could do two things. One was make sure that we had a response. We didn't want to ask questions about things where we couldn't then sort of have a conversation with the patient around their priority and their goal with respect to whatever that particular item was, and facilitate some kind of action. The other thing was to make sure that we asked about current stressors and realities rather than asking about things that may have occurred in the past, but that were not currently issues for patients. Go ahead. And a powerful example of that strategy was launching a medical legal partnership that is specific to the perinatal space. Medical legal partnerships, just briefly, if folks aren't aware, is where you embed an attorney as part of the healthcare team, and they are then able to work with individuals who identify a very specific type of social driver of health, which are health harming legal needs. In the perinatal space, we've got three social drivers, adverse social drivers that happen frequently. One are housing conditions. A second is the employment accommodations and short-term disabilities, as well as then acquisition of public benefits, and when those are wrongly denied, that is considered a health harming legal need. So just as an example, in this calendar year of 2025, our medical legal team was able to recover $164,345 for our patients who were harmed by these kinds of adverse events. And that was direct financial benefits to them and their families that were recovered in the areas of public benefits. So again, wrongful denial, paid family leave that was denied, as well as employer benefits that were not accessed, and then benefits that stem from housing supports. Go ahead. Couple of key lessons for folks that might be interested in exploring this as an option is to train your entire health team, not just providers, not one specific role, but to recognize that people talk with various members of the team about different kinds of things based on a number of factors. So everyone needs to be able to understand how to spot a health harming legal need. And then the second is specific to the perinatal space. There's many kinds of medical legal partnerships, but for perinatal, housing conditions and employment are consistently identified as legal needs within our patients, and so plan for those. Those aren't always quite as relevant for other kinds of medical legal partnerships. Go ahead. Second area, maternal mental health. Couple key lessons about how we integrated this into our service plan. One is conduct wellness assessments multiple times. And we decided to do this 3 times, one at the first prenatal visit, the second aligned, generally speaking, with the glucola assessment, early third, late second trimester, early third trimester timeframe, and then again in the postpartum period. An important component of this is making sure that the setting offers prevention options. We adopted something called the ROSE intervention, which is one of the 2 identified by the task force as being evidence-based for prevention of onset of poor mental health in the perinatal period. And then the other key lesson here is to make sure that we included multiple different options. I sort of touched on that by mentioning the prevention, but people will have different kinds of priorities, different time available. And so working to integrate sort of everything from prevention to response to acute needs with psychiatry, integrated therapy, brief targeted focused therapy are very important. Our model screened for one of our office locations, just as an example, we serve about 800 patients a year, 8 to 9 in this particular office setting. And this approach resulted in over 2,000 assessments annually, as well as about 190 patients that were engaged in some kind of therapy, as well as 53 acute psychiatric referrals. So these were individuals who needed a high level of intervention immediately, including inpatient admission through this process. Next slide. So hypertensive disorders of pregnancy affect many people. They are also a key element of addressing equity and justice in the maternal space. We added remote blood pressure monitoring as well as nurse navigation that was aligned specifically with this condition, and found these two things to be very important in terms of providing a higher level of care that was impactful for patients. Next slide. Careful onboarding is really critical with remote patient monitoring systems. Our approach aligned nurse navigators to do key steps like making sure cuffs fit, making sure patients understood how to use them, reviewed critical values, etc. And then the other piece that we learned was that with an increased focus on hypertensive disorders of pregnancy, your team will start to identify a whole lot of blood pressures as well as symptoms that people will share with the team. And that increase in sort of need for response to those symptoms is something that needs to be planned for, particularly with digital technologies. Digital technologies will identify a lot of values and symptoms that need to be responded to. And so thinking through carefully on how to do that once those symptoms are recognized is a key component of adopting these measures that will help us provide better care and facilitate earlier identification and intervention. Next slide. And our last area was an integrated program that looked at diabetes and offered integrated diabetes educators who are dedicated to the perinatal space. So rather than referring patients who are impacted by diabetes, be it as a ongoing chronic condition or gestational diabetes during pregnancy, that instead of individuals being referred outside of the perinatal team, that all of that care was provided within the core team. Some real advantages to this in terms of the ability to be able to make quick, rapid, incremental adjustments, insulin needs, and other medication needs, transitioning from diet control to medication-supported management plans happens very quickly for some individuals in the perinatal space, and we were able to be much more responsive. One of the two things that made this possible in terms of the system was leveraging telehealth. Patients found it to be very efficient. We're highly engaged. We have show rates with these appointments, irrespective of insurance type or age or location of care delivery, that routinely exceed 80 to 90%. So people are very responsive and engaged. We saw very rapid adoption from patients with this methodology. Two things that we also found in terms of our outcomes that we demonstrated quickly was that there were many more patients who were successful with gold standard therapy and diabetes management or use of insulin. And we were also super excited to find that there were no differences in terms of patient characteristics and who was receiving optimal therapy. So we found no differences in terms of race, ethnicity, insurance, or location of care in terms of successful utilization of insulin when indicated in diabetes management during pregnancy. Next slide. Tamika?
Yeah, so again, we just, we wanted to give you a very brief overview. We could talk about this for hours. I kid you not, Laura and I together, but we wanted to highlight our academic publications around this. I think this is important. We're not just so proud of the work that we're doing, but it is so important to get the results out, the research out, how to do this. At MedStar Health, you said this is not just a grant-funded project. This is how we do prenatal care. So it is very important to get the word out, to talk about this, to talk about what works, what doesn't work, and to talk about our successes. Any chance we get, we are out there trying to talk about it. We were very fortunate, a recipient of our members of our program, the 2024 Gage Award, within the District of Columbia, some other awards, and then around locally and nationally, some publications. So we are very, very proud of the work that we've done. We have to continue to disseminate, talk about it. It has transitioned from the Safe Baby, Safe Mom program to this is how we do prenatal care at MedStar Health. this is it. There's no special program anymore. This is just how it's done. So I think that's a big testament to what we're doing. If you have any questions, please feel free to contact us, myself, Laurel, or we have members that can answer questions about Safe Baby, Safe Moms. So with that, I'm going to turn it over to our partners here, Kristen and Ashley.
Hi, thank you guys so much. Yes, my name is Kristen Farney. I work for Carle Health here in Champaign, Illinois. I am the nurse manager over our community health home visiting services, and I'm joined by my partner, Ashley Polnitz, who is also here in Champaign with me and helps to serve our families living within the two counties of Champaign and Vermilion. So with that, we're going to go ahead and get started. In 2017, Carle Health set out to take a bold and innovative approach to healthcare, one that really reached beyond the walls of our organization and into the homes of some of the highest risk families within our communities. That vision became what is now known as Healthy Beginnings Nurse Family Partnership Home Visiting Services. The foundation of Healthy Beginnings is, as mentioned, the Nurse Family Partnership Model, which for those that may not be familiar with, is an evidence-based nurse home visiting model that has more than 40 years of research showing powerful outcomes for both maternal and child health. At its core, Nurse Family Partnership, also known as NFP, relies on the trusted relationship between a nurse and a mother beginning very early in pregnancy and continuing through the child's second birthday. This long-term engagement really empowers mothers to improve their health, work to strengthen their parenting skills, and just overall creates more stable futures for their families. Healthy Beginnings is built upon this proven foundation. And at Carle Health, we've expanded upon this already very robust model by integrating both early childhood educators and social workers into the team, really working to ensure that families receive developmental, educational, and social emotional support alongside the nursing care that they will be getting. And unlike many NFP models, since our inception here at Healthy Beginnings, we serve multiparous mothers. As a standard, typically Nurse Family Partnership, and when it was started with the evidence-based trials, served only primates, so moms that have never had a child before. But in order for us to really make sure that we were meeting the needs of the communities and where we saw the highest need, we needed to make sure that we were able to expand upon that model and serve moms that not only it was their first child, but mothers that have had children before. And so we also needed to be able, along with those mothers who had had children before, we also needed to be able to serve moms who maybe were entering prenatal care later in their pregnancy and might not be able to get connected to services until later, understanding that access to prenatal care can be an issue for those families that we were working to serve. By widening the access to those families and ensuring that we opened up more doors for moms, we really made sure that we were impacting the most families that we could with this model of care. Healthy Beginnings has really been transforming the way that families experience maternal and child health within our communities. And since its inception, we have enrolled over 1,000 families. We've celebrated the births of over 900 babies, and we proudly graduated. So with Nurse Family Partnership, like I said, we enroll moms early in their pregnancy, and they stay enrolled in our services until the infant that they're pregnant with turns 2 years old, getting visits every week to every other week throughout that entire time. So it really is an intense nurse home visiting model. And so we proudly have graduated over 300 families out of our services at 2 years. So today, with our presentation, Ashley and myself, we are going to really explore the role of the patient and family voice in driving quality improvement efforts within healthcare systems, and then how these voices can lead to a better and more personalized care model. We will help to identify the strategies that we utilized for implementing patient-centered care initiatives and learning how healthcare systems can integrate these practices into their own maternal and child health programs. and then take a few minutes to evaluate the effectiveness of those quality improvement learning opportunities that we had, and work to provide platforms for continuous feedback and engagement from patients and families at every level throughout the whole healthcare process. Our hope is that these, in this brief time that we have together through these objectives, we can really help guide everyone on here today, and we'll use examples from our real work to illustrate the point to understand how beneficial a service like Healthy Beginnings is.
So the very first step in kind of what we did and what we recommend is really elevating family voices. And that begins immediately in the nurse-family relationship. So every day we connect families to care. Our team connects families to care. They teach self-advocacy, and they share information in ways that close gaps and build high levels of trust. But the conversations don't really just stop there. We've built pathways so that what nurses hear daily, like barriers with housing or challenges in accessing care, can be elevated and inform more broad conversations. And then once those voices begin to move beyond individual encounters, we strengthen them through 3 core strategies that keep families at the center, which I will be sharing with you. So these are strategies that we have implemented for patient-centered care. So we keep our families at the center through 3 key strategies. First, by embedding home visiting services into the healthcare system. There are not very many nurse-family partnership sites that are integrated into hospital systems, and it has made a world of difference specific to our community. So families' voices, they're connected directly to their care teams, and they can influence decisions in the clinics, at the bedside, and then at the larger system level. Second, by ensuring families are at the center of our governance structures. So it's not only about having a patient partner or on a council or projects, but about that interdisciplinary work group and councils where those patient perspectives are shared and used to shape practices, policies, and maintain high priorities based on what we're seeing. Those structures ensure that lived experiences inform decisions again, everywhere. And then third, making sure this information travels. So alongside those narratives, we bring objective data. So outcomes related to like maternal morbidity outcomes, other identified disparities, and then measurable trends to drive that meaningful change. So again, based on those 3 strategies, we have to then turn that feedback into action. So we saw the structures, integration, feedback, and governance, but that strategies only matter if they lead to change. So that's where that continuous quality improvement comes in. And so to share a specific example with you, social drivers of health screening, which the group before us talked about, we didn't have objective data per se, but because our nurse home visitors are, in the homes and really understanding, we use the subjective information to start to drive change. So we in our home visiting services, we are really in tune with the families. Again, like Kristen mentioned, doing home visits frequently, and she mentioned the time frame. We can also extend for a second pregnancy, so we can be with families for up to 5 years. So building rapport and trust, and in that space where the client, is most comfortable. So we have the information related to social drivers of health, but it wasn't a specific screener. It was, again, just based on conversations, related to transportation, food, housing, and things of that nature. So families didn't necessarily come forward saying that any social drivers of health screening needed to change. Instead, it was through those trusted relationships that they developed where families felt safe enough to share their daily struggles with food, housing, transportation, and some of the other challenges that they had. These honest conversations revealed that, our screening process just in our home visiting service, wasn't enough. That families needed to not just be asked questions, but to be connected with meaningful resources and to have that follow-up and support. So we adapted the process, shifting to more family-centered language, strengthening referral pathways, and ensuring nurses followed up after referrals were made. So, we did broaden that effort, and again worked to share these ideas, these screening and screening methods with the inpatient hospital and the clinics to make sure that they're also screening, because we only care for a certain amount of our pregnant patients in our community. So building that work group, the service line practice council is what we call it, to really hold that high expectation of our entire team so that our patients are screened and being linked to resources across the continuum of care. We're really early on in the process, but we are very passionate and motivated to continue and then implement this change again across our service line. So yeah, it's a learning journey, and we're still taking those new actions to make sure that every family's experience of care reflects both clinical excellence and equity.
And so, like Ashley said, I think along with looking at all of that, it's really important that similar to our colleagues who presented before, we need to look at, again, quality outcomes and really taking a step back and looking across what needs to be done, what we can impact as a home visiting service, and then what we're hearing and seeing out in the community, what the families are telling us in terms of, like I mentioned before, access to care, access to quality care, not only in the maternal, prenatal and postpartum period, but also then once that child grows up, access to, quality pediatric care, the ability to get immunizations, but along with that, understand and have the support to know what your child, what immunizations they're getting and what if they're on track developmentally, and what that means when you're told that from a provider. And so we want to just kind of very briefly take a step back and look at the impact that we've had thus far in the very short time that we have launched Healthy Beginnings within currently the two communities that we serve. And we see that tangible impact of putting that family voice at the center of all the care that we provide, and then taking that voice and helping to make change within our organization. So at Healthy Beginnings, our data shows that over 85% of the families enrolled in our services have stayed adherent to prenatal and postpartum care. Along with that, which is not an outcome that's on here, but we do have a 100% prenatal care initiation, or that 100% of our moms have at least received more than likely more than one prenatal visit before delivery. So one thing that we are able to do, being connected to the healthcare system that we serve, but then also through community partners, is that if we enroll a mom in our services, and it has been identified that access to care is an issue, and maybe she hasn't been able to establish prenatal care, getting her linked in with prenatal care and showing that 100% of the moms who enroll in our services and deliver during the time that they're enrolled with us have received prenatal care to some extent. And then more than 85% of them receive at least one postpartum visit with their OB provider. Along with that, our nurses are doing a significant amount of postpartum care in the homes, really screening for mental health. So that's another really big piece, is that we are making sure that mom is getting at least one mental health screening during pregnancy, and then postpartum, oftentimes they're getting more than one. And so that allows us to have that really early detection for, postpartum depression or anxiety, and make referrals and connections sooner rather than later to support that mother. What we see is that 81% of the infants born into our Healthy Beginnings services had no NICU days, so there were no NICU admissions, which is amazing. And for those that did have to have a NICU admission, the length of stay is only 9 days compared to the Medicaid average of 14. So a majority of infants born into our services did not have to have any NICU admission. And for those that did, they had a significant decrease in the amount of time that they spent. We have breastfeeding initiation rates of around 86%. And then 83% of our children who graduate from services are on track or even exceeding developmental milestones. Throughout the time that they're enrolled with us, we have multiple developmental screening tools that we use. We use the ASQ and the Brigance. So along with development, we're also looking at school readiness, and really, like we said, really using the family's voice to not only drive change within our healthcare system, but then also out in the community on what we're hearing in terms of making sure that families have the resources that they need so that kiddos are ready for school when that time comes. These are just a few of the quality outcomes that we measure as part of our continuous improvement to work. And it feels like every day there's even a new data point that comes across that we're like, yeah, we should start tracking that, because it is a lot of times these are the way that we show impact, but partnering these with the family voice is what really works to drive change. So these metrics reflect not only the health of our mothers and babies, but also the effectiveness of building the services where families' voices guide practice. They demonstrate that when families feel heard and supportive, outcomes improve across both clinical quality measures and lived experiences.
To get started, first of all, thank you to all four of you. You all have a lot to be proud of. This is incredible work that you're doing and just making such an impact on your communities. And I love how MedStar folks, you really focused on the prenatal care piece of this. The Carl folks have the postpartum side of the equation. It's almost like we planned it that way. But lots to talk about here. So for all of you, your initiatives really centered around recognizing that each patient, each person that you see has needs and preferences that are unique, and that the care really needs to be tailored to them. So as you were embarking on this work, like, were there any things that surprised you about the patients and communities you were serving, and were there any voices and perspectives that you were missing that you elevated in the course of designing care?
Mhm. Well, I'll speak to one because I think we did a lot of work really focusing on the patient's voice, the research, the data that had been out there, and we had done some sub-analysis on things. And I remember bringing this up. The one point of view or voice that we didn't, I think, incorporate enough was actually the frontline staff. We had a couple things where, and we know this, your frontline, your nurse, your bedside nurse that is taking care of you is hearing things and seeing things, dynamics in the family, in the room that we don't see in the outpatient arena, or we're not even considering. So we pivoted quickly to get some feedback from our frontline staff, both our bedside nurses, our physicians, midwives, even our resident physicians, just because, again, they're different roles. They're with the patients and the families at different times. And we know that every member of the team gets a little different piece of the patient. So to me, I was very surprised by that, very surprised to learn that. So that's one thing that I'll share.
I'll also add that that I think the primary partner of the birthing individual was also someone that we maybe often miss, and that is an area where we're trying to be very intentional at this point in terms of moving forward. Sometimes that's a male partner, sometimes it's not. But I think that's a area where we were in some ways more intentional around other birth workers, and being responsive to that in some ways before recognizing that we needed to be thinking about those other kind of primary support folks that were internal within the family.
I can share from our perspective. So we serve a large immigrant population within our services. However, one of the most eye-opening parts of this work has been recognizing the depth of need among our large Guatemalan population. If any of you are familiar, our Guatemalan population speaks a language that is very difficult to obtain translators for. And there are many different dialects, where even a conjugal is the language interpreter may not be effective due to those different types of dialects. So we knew there were language and access challenges, but we just underestimated how many unique barriers they face in maternal child health, from how they access prenatal care to what supports they need through that postpartum period. And these barriers aren't necessarily visible across the system. What we find is this population is typically only seeking care when they're having babies and then when they're taking their children to seek care. So, excuse me. So really our work has pushed, these needs to the surface, making them known and advocating for more culturally responsive solutions, not for just them, but all of our clients that are limited English proficiency. And we've worked really intentionally to build relationships with others who can support our efforts in mitigating those barriers. So that's a group of individuals that, while we knew may have had some, barriers, we really just didn't understand to what level.
Fascinating. Kristen, anything from you? That is okay. So both groups talked a lot about, integration in this, for MedStar, that it went from a grant to just being part of how you provided care, and for Carle Health, how you're really making nurse-family partnership like part of the health system. So I guess we'll start with the MedStar folks. Can you talk about what it took to take this from a grant to integrating it into your workflows, and just how care is provided? And, I see some questions in here about, how you've been able to make that payment model sustainable.
I'm going to let Laurel talk about the payment management, because he did a lot of work with our Medicaid NCOs in the city to get services covered. So the short answer, there's a way. But in terms of making this just the way we do prenatal care, the grant was funded for 5 years. Early on, we saw the differences that this was making. Not just the data, but the stories, the patient care stories. And so it was a combination of both. We recognize that some things would probably be able to be covered by Medicaid, some things would not. So honestly, as a larger organization, we really had to engage with our philanthropic partners to say, this is how we're going to have to do prenatal care. What can we do? Who else can we partner with for more sustainability? The other thing was to, this is just very practical and very logistics, is that when we started seeing the importance, it was hard, tough conversations with the system, leadership, and organization, and saying, so we're going to put this in the budget because this is how we have to do prenatal care. We showed them the initial evidence, and it honestly, it wasn't a hard sell. In the world of obstetrics, what's better? Spending X amount of money on a certified diabetic educator, or unfortunately a payout for an obstetrical case, right? The math works, right? So it was the staff, the frontline staff, the people in the grant working very hard. But then I had to bring in a layer of my leadership team to start having those hard conversations about, this is just the way it has to be. So, but that started early. It didn't happen in a year. It didn't happen in 2 years. It took years really to bring everyone together to say, this is just how we have to do prenatal care. But Laurel, do you want to talk about the Medicaid MCOs and some of the things that they're covering?
Sure. So some pieces of this are easier to cover than others. So for example, a diabetes educator is someone who can submit a bill for services. Right now, launching a new service line and launching a different kind of integration is an expense that isn't going to be covered by billing. But once you have folks in place and things, there are parts of this that you can just submit a bill for. Remote blood pressure monitoring is another example of something that is being, it's now being recommended as a standard piece of care for certain time frames. So there are parts of this that are more easily funded. Mental health services are another example. The key piece, though, Tamika talked about sort of that risk-benefit equation internally with systems, but the payers are very responsive to these models if you can share outcomes as well, because poor outcomes are very expensive. And that's not like my primary driver as someone who cares deeply about families and people, bringing humans into the world, but it is a component of the conversation that is really easily facilitated by that. There's also, I think, just a little bit of, making sure you think strategically about things that are not generally defined as clinical care, but that impact those outcomes, improve those outcomes. We found our local Medicaid organizations to be very interested in potentially paying for legal services when they were provided for patients, because it improved outcomes. And again, poor outcomes are expensive. Value-based care systems and states that have value-based care systems are going to also find these kind of models to be very attractive because of how they improve care.
Yeah, that's great. And I think you both spoke to the importance of engaging stakeholders and just having that data to back up why the right care is the more is just the better choice for everyone. Kristen, it looked like you wanted to jump in there.
Yeah, I think sort of looking from our perspective too, and I think agreeing with what Tamika and Laurel said. I think what we understand or what we see is that when you want to reduce maternal and child health disparities, it really needs to become an organizational priority and needs to be embedded at every level. So from your executive leadership, to your systems leaders, to your financial teams, and probably most importantly at the top, your frontline care providers. Here at Carle, when we started this work as Healthy Beginnings, it really was championed by our executive leadership and board of directors, who invested both financially and strategically in the work and in the goal of advancing maternal and child health. And so I think their commitment from the very beginning really helped to solidify that this wasn't just a short-term project, but really a sustained organizational goal. And I think equally as important is that collaboration across the disciplines. So we have worked to build partnerships with executive leadership, maternal and child providers, staff across different disciplines and multiple different areas of the organization, from OB-GYN to pediatrics to early childhood development and educators, social workers. We have community health ambassadors. And so really taking a multidisciplinary approach allowed us to weave that equity into clinical practice, but also continue to have that strategic plan simultaneously alongside our plan of how to provide care outside the walls of our organization. And so I think really that alignment between our leadership commitment at really that top level, along with the financial investment from, like I said, our board of directors, and then as we have grown, that ability to tap into different community entities, and then also just that cross-disciplinary partnership has really helped to make sure that reducing these health disparities isn't just one single program's focus, but really part of here at Carle Health, our overall organization's vision and roadmap for community well-being.
Absolutely. And I know that having all that data is always helpful in making the case and telling the story, but also these are real humans with real human stories. So do you have any stories from your patients or communities that could help, bring this to life? That we'll all walk away being like, oh yeah, that was powerful. I see you all smiling. I'm sure you all have stories.
Yeah,
go ahead,
we
Ashley.
do. We have, that's hard. If I shared my favorite story, we'd be here for a while. But I think just due to the nature of our work, our teams walk along the side of their families, again, anywhere from 2 and 3 to 5 years. Most of what we see is related to social drivers of health, but not only that, still the limitations and barriers that they have. In many cases, we've been able to resolve an issue like transportation, but maybe constraints within our system still may not have allowed us to meet our goals. When we are able to do that and really break down those barriers and have higher system level conversations, those are the best stories. So again, we have so many stories that are impactful, both good, our wins, we got to celebrate those, right? And the bad, where we have opportunities disparities, and we're sure to address, issues. But again, celebrating is definitely a component of that, and that is largely due to the work of our staff. They are the ones that are sharing stories. When there's an issue, I invite my team members to communicate on behalf of their patients or clients, if their clients cannot, because they just truly understand and have a way of conveying, their family's story to make it impactful and allows, others that we are working with to really be motivated and passionate about driving that change.
Yeah, I think just kind of tacking on to Ashley, that's kind of what I was going to say. We could share, a ton of stories of clients where we've had, we call like really good saves, and we've been able to prevent maybe a really negative outcome. But I think the story is not specific to one client that I think makes a difference. And that is really just that the real champions in the work that we're doing here at Carl's Healthy Beginnings are our frontline staff. There are nurse home visitors, our community ambassadors, our social workers. I think all of us who have been doing this for the short amount of time that we've been privileged to do this work have said, as nurses specifically, I do approach nursing care much differently now after doing this work than I did. And a majority of us came from inpatient and clinical settings. And it looks very different. And I guess we didn't know. But I think just knowing that our home visitors and our home visiting teams are the ones who are really out there making the difference and bringing the stories and the feedback and elevating that family voice to make really, really significant change. One thing that I think of right now is we have a nurse home visitor who had a family who, it seems simple, but was given discharge instructions and medication instructions in the wrong language. And so our nurse really took this champion. She was like, I'm going to call the pharmacies within our community and find out, do they have the ability to provide medication information and instructions in other languages? Because if they don't, we need to figure that out. But if they do, we need to understand, is there something that we can do as an organization, as providers, when we're ordering, to make sure that families are getting, discharge instructions and information about the medication that they may be taking or giving to their children in a language that they understand. And so that right there it's a work in progress, but it's one client that shared that, but not one person who's impacted by that. And so I think, just really the stories that our nurse home visitors and our, community ambassadors and social workers hear and then bring back to our organization is what is so impactful to us.
We don't have an endless amount of time, but I know Laurel and we have the list of stories. One of the themes that we saw in the stories was the effect that we had with our P-Law program, with the legal assistance. That was just such a game changer. It relieved and helped people survive and thrive. The stories about the assistance from the legal services are just endless. So I know that was one thing a huge thing that I took away from this.
Fantastic. Laurel, anything you want to add there?
Just quickly, I think we also should just recognize that in healthcare systems right now, there's a lot of burnout, there's a lot of compassion fatigue, and particularly in maternal health, given that it is a system that is challenged from multiple directions, that one of the benefits, and I guess speaking about who may be in our audience today, another reason, as if we need another reason, but another reason to adopt these approaches is that your workforce will be more engaged, they will be happier, they will be more satisfied, and they will be more able to show up as their best selves in the context of delivering care, and they will be much less likely to leave. And I think that's the thing that I think we also heard and hear over and over again is that, in this kind of model, I can be the nurse, I can be the midwife, I can be the doula, I can be the physician, I can be the surgeon that I want to be and that I was signing up to be. And that's only going to be increasingly important.
Absolutely. And I think we have time for one more question. I'm going to pull this one from Ariel, who is asking that for health systems that want to redesign their maternal health, where should they start and what needs to be in place to launch and sustain revamped maternal health programming?
So I think that hearing both presentations today, there's a lot of things. I think if you're going to start, I think you got to start with one very clear focus and think about how feasible it is, how it's going to get funded. You got to look for funding. Is going to take time. It's not going to happen overnight. It's not going to happen in a year. I mean, Laurel, there was 2 to 3 years of prepping for this launch, right? And so be patient, focusing on, look at the data and from your own organization, what is the highest need or the biggest, for lack of a better word, biggest bang for your buck? Where can you do, and something that's feasible, right? That you can show a difference, because the minute you start to show a difference, oh, things are going to start coming. Things are going to start coming. They're like, oh, can you work on this? And then how about this? You have a team, you have a process, you show a difference, then the expectations is, are you going to apply that to another problem and then another, and then before you know it, you blink, you're going to have redesigned how you do maternity care.
Excellent.
I completely agree with Tamika. And I think, yes, it is not done overnight. I think you have to assess, if you're talking like us as part of a healthcare system, you need kind of what I spoke to before. I think starting, you need that support of the stakeholders. You need people who see the vision. You've done the assessments, you have the data, the proof, right? The proof is in the pudding. So you have that data to say, like, this is what we're seeing. This is what is happening right here, right? We all need to take our rose-colored glasses off and understand that maybe we're not. I mean, we're doing amazing things, but how can we do even better? So for us, I think it really started with that understanding that we had the support of our organization behind us. And then truthfully, funding, we'd be remiss if we didn't say funding has to be there, but get creative with that and figure out, what does it look like? How do you start small? Sustainability, don't just, that's been big. Something that we've talked about a lot is I don't want to just do something unless I know what the sustainability plan looks like. And then for us, what's been huge is the team that we've built. And so we weren't just looking to put warm bodies in positions, similar to what Laurel said. Burnout is real, and we had to find and still continue when we have any open position on our team, regardless of what that position is we are identifying people that want to do the work that we're doing, understanding how challenging it can be. And people that are really driven to do the work and feel called to do the work, because it is very different. It's a very different approach to healthcare than you may be used to. And you're seeing a different side of it. And so we always say we are so incredibly proud of our team, and that is because they truly have the same drive and vision, I think, across the board. Like I said, if you're talking from an executive level to frontline staff, all of us would show that we have the same drive and vision for this work.
I think the only thing I would add to that is pretty critical to launching and redesigning is make sure that your team has an extraordinarily high level of tolerance for change and rapid pivoting and innovation. Because all your evidence-based work needs to be fit into your system. And no matter how much of that you think you need, add another layer on top of it. And then don't forget to plan for like the transition of you need your energetic, high change tolerance, visionary folks to get this stuff launched. And at some point, it will become part of your system. They'll start to get a little restless because that personality needs all of that. And then you'll need your managers and your people to sustain that really want to be in the work to keep it going. So plan for that transition as well.
Laura, you're spot on with that. We say we wouldn't be Healthy Beginnings, our community health initiatives, if change wasn't a constant in our world. So yes, you have to have the ability, you have a team that has to be adaptable. So, and okay to not sit stagnant for very long.
Absolutely. And the healthcare field, never a dull moment in the healthcare field, and things are always changing. But I think the way that you're doing it. You're changing things for the better. So Laurel, Tamika, Ashley, Kristen, thank you so much for joining us, your insights, and more than that, thank you all for the work you do every day to serve your communities and your patients. It is really, truly inspiring to see how you're improving maternal and infant outcomes for the communities that you serve.